Welcome to today's Public Health Ontario's Rounds presentation on Legionella in healthcare settings when risk becomes reality. My name is Rena Chung. I am the Director of Environmental and Occupational Health here at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. Our speakers and moderator and myself will make every effort to address as many questions as possible. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. And I'd like to state that as the moderator of the session, I do not have any conflicts of interest. So it's now my pleasure to introduce the speakers for today's presentation. Dr. Catherine Sue was previously the Medical Director of Infection Prevention and Control at the Ottawa Hospital and is now returned as the IPAC Medical Consultant to the Ottawa Hospital. Jessica Fullerton is the Regional Infection Control Healthcare Facility Design Program Manager based out of the Ottawa Hospital. And last but not least is Ron Drummond, who is the Executive Director, Capital Projects and Facilities Management for the Ottawa Hospital. So looking forward to hearing this presentation. And with that, I will hand it over to Catherine.
Great, thank you very much. To begin with, thank you all for joining this webinar. And from the TOH team, we would like to thank Public Health Ontario for inviting us to share our experience with all of you today. There we go. Thank you. So none of the presenters today has any disclosures or conflicts of interest. At the end of this session, we hope that you will be able to recognize factors that promote Legionella persistence in healthcare settings, that you'll be able to list at least 3 key steps to mitigating the risk of Legionella in your facility, that you'll know 3 limitations of Legionella testing, either in people or in the environment, and that overall you will be better prepared to formulate practical plans, first of all, preparedness, but in the event that you have to respond to a presumed healthcare-acquired Legionella case or a Legionella outbreak in your facility. The outline for today will be as follows. We'll provide you with a brief overview of Legionella, focusing really on the points that are salient to this presentation, so not a lot of clinical information here. We'll share with you a case study from our experience. We'll have a session on understanding your water and plumbing systems better than perhaps you do already. We will share some of our lessons that we've learned from our experience and discuss some future considerations for risk mitigation. Legionellosis are gram-negative intracellular aerobic bacilli. They are ubiquitous in fresh water, including rivers, lakes, streams, ponds, in water systems, including hot and cold water tanks, plumbing systems, faucets, shower heads, whirlpools, and also in the environment where they have been identified in soil, but are also present in things like potting soil mixes and compost. There are over 60 species of Legionella, of which at least half can infect humans. But the key points are that Legionella pneumophila causes the majority of human disease. And of those serogroups of Legionella pneumophila, there are 4 which cause the majority of human infections. You can see here 1, 3, 4, and 6, but it really is serogroup 1 that causes the majority of infections. And in North America, this is between 70 to over 90% of Legionella cases. In other parts of the world, serogroup 1 may cause a lower proportion of human infections. Legionella grow best in tepid water, generally between 25 and 45 degrees Celsius, although they have been known to survive in cooler water, around 20 degrees Celsius, and also in warmer water above 55 degrees Celsius. They like slow-moving water, and they like biofilm. Biofilm has amoebae that feed on the biofilm itself. There are many different amoebae that do this, but one of the unique features of Legionella is their ability to invade, persist, and replicate within amoebae. And this is felt to perhaps offer them some protection as well from chemical and thermal insults in water. You can see then how, for example, dead-end plumbing or stagnant water in plumbing systems, particularly where water is tepid, offers a very favorable environment for Legionella to survive. On this slide, I've just tabulated the cases of Legionella that have been reported to the province of Ontario in 2021, 22, and 23. 23 here has an asterisk because these data are only until the end of October. But you can see in general that our rate per 100,000 population is more or less stable between 2 and 2.6 per 100,000. And also that the rate of hospitalizations and deaths are more or less stable, around 70% and around 5% respectively. Recognize, of course, that hospitalizations and deaths are primarily due to Legionnaire's disease, which is Legionella pneumonia. There is also Pontiac fever, for which patients generally do not seek medical attention. The incubation periods for these two clinical syndromes are different. For Pontiac fever, symptoms generally develop within 48 hours of exposure, but for Legionnaire's disease, the incubation period can be much more variable and much longer. So from 2 to 14 days in general. There have been longer incubation periods that have been cited in the literature, but the median incubation is 4 days, and most cases will become symptomatic within 10 days of exposure. Transmission is generally felt to be from inhalation of aerosols containing Legionella, but aspiration of contaminated water has also led to infection, albeit much more rarely. Importantly, the infectious dose of Legionella is also unknown. When we talk about lab identification of Legionella, we have clinical specimens and also environmental specimens that we can send for testing. Clinical specimens that are suitable for diagnosis of Legionella include respiratory specimens. This includes sputum, bronchoalveolar lavage samples, bronchial washings, as well as pleural fluid and lung tissue. And we can also diagnose Legionella from urine and blood. I've listed here the main assays that are used in our public health lab. PCR, or polymerase chain reaction, offers the highest sensitivity and specificity primarily for respiratory infections. However, you will see here as one of the limitations that PCR is not yet Health Canada approved, and it is not validated for testing respiratory specimens, which is a little ironic. Other limitations of PCR are that it does not distinguish between living and dead bacteria. It does not allow sample on which typing can be performed. So typing we'll get into a little later, but that is one of the key test results that we would look for epidemiologic investigations. And the turnaround time from receipt in the public health lab until you have a result for PCR is generally 4 days. PCR can be used on urine and blood, but the sensitivity is much lower, and these are not typically offered with the public health lab testing. Culture is considered the gold standard for Legionella diagnosis. It's important to remember that you have to specifically ask for Legionella cultures to be set up, because a routine, let's say, sputum sample for bacterial culture will not include the appropriate medium that is required for Legionella to be identified. Most isolates of Legionella will grow between 3 and 5 days on culture, but it can occasionally take much longer, and even up until 2 weeks, until isolates start to grow. So the turnaround time that's cited from the public health lab here is 15 days to get a final result. Clearly, I think if there's a culture that's growing earlier, you would find out about that earlier. When we're talking about respiratory specimens for both PCR and culture, lower respiratory tract specimens are generally preferred. So deep specimens, sputum may work, but specimens from bronchoscopy are also very good. DFA, or direct fluorescent antibody, is a more complicated test. Is generally not routinely performed because it's difficult. It's not one of the tests that's offered in our lab in Ontario, but it may be available elsewhere. Urine antigen detection is the one test that performs very well from urine. Again, limitations of urine antigen detection are that the current test only identifies serogroup 1 infections. So if you do have an infection from other serogroups, you won't pick it up on this test. The sensitivity is 70 to 75%. And it's important to realize that while most patients with Legionella infection will become urine antigen negative within about 2 months after their infection, some patients will have a persistent urine antigen test that is positive for up to 12 months. Serology is helpful for confirming diagnosis. It's not clinically useful in real time. It does require an acute and convalescent sample to be obtained, which may pose some challenges if patients have passed away, or also if patients don't return for follow-up samples. So we generally don't rely on that for diagnosis. This slide is a summary from the CDC and just highlights the different sensitivities and specificities of the test that I just described. We can also test for Legionella from the environment. So again, we have the same types of tests that we can offer. We have PCR, there's culture that's available, and there is also a rapid antigen test that is available for water samples specifically. PCR, again, is done in the public health lab. If you do have an independent environmental contractor that is working with you, they may also have labs that they work with that can provide PCR results as well. These can either be qualitative or quantitative PCR results. Culture, again, is important. Similar principles to clinical cultures. Culture allows growth of Legionella that can permit typing, which again is invaluable in outbreak investigations in particular. It is important to know your test kit that you're using or that your lab is using and the limitations of those test kits. So for example, some PCR tests will only detect Legionella pneumophila serogroup 1. With the public health lab, we can identify Legionella species, Legionella pneumophila, and Legionella pneumophila serogroup 1 from water. Rapid antigen tests are available. These are available commercially. They're similar to rapid antigen tests that we've become very familiar with for example, with COVID. These do have limited sensitivity, however. And last, when you're sampling the environment, it's important to think about what sampling locations you are obtaining your specimens from. Clearly, if there's a point source like a faucet or a shower head that is close to a patient that you may feel may be implicated in transmission, that would be important. Prior water treatment may matter. So if you've recently superheated or chlorinated your water system, your tests may be negative, and that doesn't exclude the presence of Legionella in your water system. Swabs versus water, both can be collected. Water is preferred by the public health lab in large quantity. It allows for the sample to be concentrated, but for testing, for example, sink faucets or shower heads, swabs are preferred. You can actually get in and get a sample of the biofilm that's present. And logistically, we can get into this later, but it's important to think about the operational aspects of collecting this in your facility, who can do this, and how long that might require. Strain typing is invaluable, again, for particularly outbreak investigation, but also if you're trying to link clinical cases that you think might be hospital acquired or healthcare facility acquired with Legionella that is in your environment. The current gold standard for strain typing is sequence-based typing. This is a method that uses a combination of 7 housekeeping and virulence genes that are present in Legionella to identify different sequence-based types. And currently there are over 2,000 sequence-based types that have been identified. There is some question about how discriminatory sequence-based typing is, because a lot of infections and a lot of environmental samples tend to be caused by relatively few sequence-based types of Legionella. Whole genome sequencing is evolving, but is not currently widely available. But when you do get sequence-based typing results back from the public health lab, in general, you would compare a clinical isolate to an environmental isolate. I've shown here as an example a clinical isolate that's sequence type A, although this comes back as sequence type number, being different from environmental isolates that are sequence type X. And so this may allow you to support or refute the role of your particular environment in clinical illness. We're moving on to a case study that we had an experience with one case of lab-confirmed Legionella pneumophila pneumonia in an inpatient who was admitted to our facility. This patient had been admitted to only one room in the facility and developed symptoms of respiratory infection on day 13 of admission, ultimately had bronchoscopy, and a BAL sample was positive for Legionella on day 16.
All right, so in our situation, for our case study, the first things, and I say plural because as Kathy's last poll question indicated, there's usually things you do in multitude. We're often not doing them in a stepwise fashion. So we initially halted access to potable water on the affected unit and moved to bottled water only. We also deployed the use of point-of-use filters on the unit in question, as well as other high-risk units within our facility, patients that were more immunosuppressed or immunocompromised. And then we also conducted an environmental audit of the unit in question it was a bit of a long shot to try to identify any obvious sources. So, humidifiers, areas of standing water, anything that would potentially aerosolize the water system. And for those that may not be familiar with what a point-of-use filter looks like, this is one type. They can be installed on faucets. They also come, shower heads are available. One of the things to note is that they don't fit on all fixtures. So you do need to make sure, that you have the correct adapters to connect the filter to the fixture. And even then they will not fit on all plumbing fixtures. And the image on the right is actually our MacGyvered shower head. We were challenged in finding inventory for shower heads. And we had patients that really wanted to shower. They were going on days into weeks of no access to shower facilities. So our plumbers were incredibly instrumental in fixing up areas so that they could shower safely. Kind of moving along the timeline in terms of what was conducted, we notified our local public health unit and started coordinating the sampling of our domestic water. So we were lucky in that at least the index patient had only been in one room prior to symptom onset. And so we were able to kind of really localize our testing to in and around that room and areas adjacent, as well as vertical. Ron, in a little bit, is going to get into our specifics about our plumbing system, but our plumbing system is based on vertical risers, which meant that we were looking both above and below the index room as well. Out of 10 samples that were collected, 9 were PCR positive. And just to note that, as Kathy mentioned, qPCR was not available with the public health lab. So it's just a yes or no. So we knew we had Legionella in our system. We did not know how much we had. Of those 9 culture positives, they were all the PCR positives were sent for culture. Of the 9 PCR positives, 2 came back positive on culture. But obviously, we didn't receive that culture result until about 2 weeks later, as Kathy indicated in terms of the turnaround time. We also retained our environmental consultant. This was really challenging, and I'll provide a timeline momentarily, but it really took us a few days to find an environmental consultant that had hands-on experience with Legionella. There are many that know the theory, but we also knew the theory, and so we really needed someone that had the hands-on experience with contaminated water systems that could help guide us. Also needed an organization or a company that had an affiliated accredited laboratory, because public health didn't have the capacity to do ongoing water sampling. We would be doing it in bulk. We had lots of areas that we needed to sample and test in our investigation. And so we really needed to employ that third party to actually do the testing as well. And then kind of as we're doing this, we're also planning for a full system disinfection. So with our consultant and the help of our local public health unit and Public Health Ontario, we determined that we really did need to disinfect our entire plumbing system to I won't say eradicate, but to really minimize the concentrations of Legionella in our system. Hyperchlorination is considered the gold standard for disinfection, although superheating can be used in instances where hyperchlorination may not be appropriate. And then we were putting together our hyperchlorination plan, and that was certainly no easy feat. That took several days of coordination to put together a plan on how we were actually going to implement this. So essentially with the hyperchlorination process, you need a way to add chlorine into your domestic water system. And so we had to go out and find a contractor in addition to our environmental consultant that had experience with these systems, and installed a chlorine pump on our incoming water, our domestic incoming water line. And that pump was able to monitor and regulate the concentration of chlorine that we were putting into the system. You also need to make sure that hot water tanks are drained down, because you want that water, that chlorinated water, to go into the hot water tanks and then flow through the plumbing system. Then once we had the chlorine in the system at the correct ppm, we then needed to flush every outlet in our inpatient tower. And our inpatient tower runs from floors 4 to 8. And so this was upwards of 3,000 fixtures. Every faucet, every shower, every toilet, everything needed to be run to get that chlorine concentration to the outlet of every fixture. That chlorine then sits in the system for about 2 to 24 hours. The specific time is determined by the CT value. So the CT value is the chlorine concentration at the outlet and the disinfectant contact time. So there's no, one size fits all here. It really is a kind of, you test as you go to make sure that you've hit that CT value. And then once we have hit that CT value, that chlorine is sit in the lines, we then need to repeat the process all over again, reflush those 3,000 fixtures to get the chlorine levels back to baseline, to flush out all of that additional chlorine. As a part of this process, we also removed all of our shower heads and laminar flow devices from our faucets. Aerators are already not permitted in healthcare facilities. Certainly some older ones may still have a few hanging around, but because of that risk of aerosolization of the water, aerators are not permitted. So removal of shower heads and laminar flow devices, disinfecting those. We sent all our shower heads to our medical device reprocessing for high-level disinfection. We also had to do a bit of a risk assessment because we weren't sure, as a part of this flushing process, we're not emptying patient rooms. We can't empty an ICU room or, a neonatal intensive care room to do this flushing exercise. So we had to do it with patients in these spaces, and we did need to do a bit of a risk assessment to make sure that we weren't putting those vulnerable patients at risk. So looking at additional enclosures, covers for the sink while we did that initial flushing. Chlorine off-gassing was also a consideration. It was brought up by our occupational health and safety physicians, and it can be a concern for vulnerable populations such as respirology and NICU. We did have some carbon-filtered construction air handling units at the ready should the chlorine off-gassing be a problem. Thankfully, in our instance, it was not, but certainly something to consider. Kathy already mentioned the issue with dead legs. So certainly Legionella, it loves that optimal growth temperature between 25 and 45, and it loves slow moving stagnant water. And so dead legs certainly contribute to that. And in very large healthcare facilities that are older, that have been renovated over the years, we end up with a lot of these inherited dead legs, unfortunately. And so as a part of our flushing exercise, we actually uncovered a number of them. Abandoned housekeeping closets, showers that hadn't been used in years. The image in the middle there is actually a hopper in a solid utility room that had been removed and the plumbing simply capped at the wall. So there is a requirement that when we do remove a fixture, a plumbing fixture, you need to take that plumbing line back to the main. So remove that out of use plumbing line back to the main so that you don't end up with an area where you've got stagnant water sitting that then has the potential to be siphoned back into the supply line. And then similarly to many buildings, not just healthcare facilities, but we closed down use of our water fountains during COVID. And unless those systems are drained down, which means you're draining the water out of the plumbing lines, again, they're just sitting there holding water that if you do have bacterial growth in, you're just going to exacerbate the issue. We also some interesting dead legs that we uncovered. We have a unit in our inpatient tower that used to be inpatient rooms. It was converted to clinic and office space, but we never removed the 3-piece washrooms that were in those patient rooms. Apologies for the overhead announcement. And so, and really, this wasn't forward thinking in that, you know, if we ever converted this area back to inpatient usage, we really wanted those 3-piece washrooms in place. But many of the showers had been capped, as you can see in the left-hand image there, but the water was still in the lines. And so when we uncapped those and actually flushed the water out, there was probably decades of stagnant water sitting in that line. So you can just imagine what that water looked like. And then the image on the right is the same shower, but the inhabitant of this office had actually converted it into a lovely reading nook bookshelf, and was not too pleased that we actually had to dismantle it in order to do the flushing. So this is kind of a timeline of our process here, and I'm not going to go through each step individually, but just to give you an idea of the length of this entire process. You can see on the far left-hand side, day 0, these things always happen on a Friday afternoon. It never fails. And so really kind of putting those steps in place in terms of, you know, contacting our local public health unit, getting water testing, getting our environmental consultant, establishing our IMS structure. So this was considered an internal emergency for us. And so we did have emergency management supporting us, which was instrumental to our being able to respond. The hyperchlorination process itself. And then finally, when our final sequence-based type testing was received. So we're looking at, you know, 23 days of no water. So having these high-risk units still without water for this length of time is a massive risk in and of itself. So really, you know, when you are determining the right time to turn that water back on, you really have to do a risk assessment based on who's in the building, your patient populations, and what the risk is of not having water to these areas. So kind of at the end of that hyperchlorination process, you want to resample about 10% of your fixtures. And we did, because they were being sent through our environmental consultant, they were able to be sent for qPCR and culture. We did base our decisions on the qPCR testing. We did send those for culture. However, we determined we could not wait an additional 14 days to get those culture results. So we were basing the majority of our decisions on qPCR results. And as I mentioned before, very unlikely you're able to eradicate. Once you do have Legionella set up biofilm within your pipes, within your plumbing system, it's almost impossible to get rid of completely. And so it really does come up to risk management, risk mitigation, trying to minimize the amount of bacteria in that system to the best of your ability. And then after that hyperchlorination exercise, there is a requirement or a guidance that repeat sampling is done every 2 weeks. And then after 3 months, it's done quarterly. So every 3 months after the initial 3 months. And this is taken from guidance documents from CDC and Ontario MOH. Again, this is the table taken from the MOH Legionella guidance document, which was also taken from CDC, so it's certainly not the original resource, but this document was really one of the only ones that we were able to find in our initial investigation that gave some guidance as to what concentrations we're looking at here. There really are no standard industry standards of what's a safe Legionella concentration and what's not. So our localized follow-up action had been replacement of all shower heads and hoses. So we determined in our instance, we did swabbing, environmental swabbing, and we actually didn't get any hits on any of our hoses or fixtures. So unfortunately, that's not where the biofilm was living. If it had been, it would have been an easy swap out. But we did kind of go through some of our older shower heads and hoses and started an approach to replace those. Replacement of old faucets. This, one of the good things that the hyperchlorination exercise gave us was identifying dead legs and also identification of old faucets. So because we are such a large building, we're an older building, we have, I'm not sure how many, maybe 20 different kinds of faucets within our facility, which makes it really challenging for our operation and maintenance folks. We did also go back into an audit of unused fixtures and plumbing dead legs, and that let us institute a flushing program. So to keep the water moving. So we looked at temperatures for sure, and Ron's going to talk about some of the infrastructure items, but we wanted to make sure that we're avoiding stagnation as much as we possibly can. So making sure that we keep the water moving, and we actually have an individual whose job it is to go around our facility and flush every fixture twice a week to make sure that we keep that water moving. And then additionally, some check valves. Check valve is kind of like a backflow preventer, specific kind of backflow preventer. And we want to make sure that these check valves, they're meant to prevent the cold water from bleeding into the hot and the hot water bleeding into the cold, which would then put that temperature, that water temperature, in that optimal Legionella growth range. So those check valves are really important to prevent that.
Great, thanks, Jess. So I'm here today to talk a little bit about potable water systems in healthcare. So I came to facilities management and healthcare from managing large building portfolios and delivering projects in mostly commercial and industrial settings. And it's safe to say that my introduction to healthcare was a little bit shocking, and it's not the run-of-the-mill commercial operation. Of course, there's lots of common areas and public washrooms that are typical to both commercial and healthcare. But typically, healthcare is far more complex, and typically we serve higher risk situations or populations. So we got odd systems like dialysis, clean rooms, labs, ORs, food preparation, you name it. These are all areas that eventually will touch those vulnerable populations. From a facility standpoint, our goal is to ensure that patient and staff safety are maintained through our operations. There are many considerations we take into account in delivering this mandate. And it's all to deliver clean and safe potable water using proper materials and safeties to limit the contaminants and ensure that the water delivered is safe and free of bacteria. We'll take a look over the next couple of slides at some of these considerations. And we'll start with a look at the risks that are out there. So patient safety depends mostly on ensuring that the water entering the facility meets all the applicable quality standards. The plumbing on site, that's like the building's hot, the building's cold water systems, it's designed and it's maintained in a way that minimizes growth and spread of waterborne pathogens. And we want to limit the exposure to infection risks to our patient populations from water. So potable water quality can be affected internally or externally. External to the building, your local provider can often be a source of that contamination. It could be a loss of chlorine at the source. Oftentimes, I know for us at the Ottawa Hospital, the city does test its pressure a couple times a year. And during those times, we can see drops in pressure that could raise some of that bacteria getting into our potable water supply. So we have to watch out for that. There could also be failures outside of the building, main breaks, etc., that will lead to contamination of your potable water supply. If you have a main break outside your building, you're likely going to have to do a hyperchlorination exercise once that water is turned back on, regardless of whether you have Legionella or not. Internally, lots of factors affect the quality of your water. These include plumbing system age, so materials for construction and state of the infrastructure. The initial design and subsequent renovations, Jessica talked about this, a shower that gets turned into a library. That's not something we typically plan on when we engineer and design a system. Other things that can happen over time or at the initial development of the building are cross connections. So these are our systems that are connected improperly, either at original construction or during renovations. We also have dead legs. We have check valves that may have failed over time, and it leads to that bleeding of water between one side and another. As mentioned before, water stagnation is a major concern. We try to alleviate that. One particular factor that is affecting water quality now is water conservation. Water conservation is great. We should all be striving for it. But in limiting the amount of water that's going through the system, we often don't change the pipe size of the plumbing systems that are used to convey that water. As a result, the velocities get slower, and that can lead to biofilm growth, and that does, as we talked about before, it might promote bacterial growth in the system. So our hospital, so shown here is how potable water is delivered to our hospital and throughout our internal network. So the city of Ottawa provides the potable water supply. It goes through some backflow prevention at the inlet to the building. It's split there to feed both our fire protection system and the general water for the hospital. The fire protection has backflow prevention on it as well. That water there is stagnant all the time. So that double check valve that we have between the potable supply and the fire water supply is imperative in protecting the quality of our water. And then on that potable side, we deliver to all the various users in the system. So it goes to our domestic hot water system, dialysis. It goes to our labs, our central utility plant, where we do our chilled water, our chemical injection, etc. Goes to the patient wards, amongst many, many others, including food prep. On the right here is a screenshot from our building automation system. This is where our hospital engineers can view and modify the regulation of the hot water in the system. We have a certain set point that we want to achieve. If ever we see that the system is low for some reason, we're able to investigate why or adjust the inlet heating to those devices to make sure that the water circulating throughout the hospital meets standard. All right, so on the right there, you'll see a layout of our hospital, or our main building at least. So it's a typical a floor plate, a conventional H configuration, and that H configuration is something we see in a lot of healthcare because it lends itself to more daylight for patients and staff. Our building's about 50 years old, and it consists of 8 stories and a rooftop for a lot of our mechanical equipment. So our cooling towers are up there, which means that potable water has to go, right from the source at the ground up to that rooftop. Our domestic plumbing, that's cold water, our hot water, and the hot water recirculation, it travels up the building in over 90 different risers to serve some small clusters of users. So on the right there, we have sort of these green locations. Each one of those locations is more or less one of the risers in the hospital. So you can imagine trying to figure out where Legionella is and where it can where it goes can be quite the initiative. At each floor and each user, we also have shut-off valves, and this allows for localized maintenance to be performed. And we also have balancing valves installed in our hot water system. And this tries to equalize the available flow between areas that are closer to the source and areas that are further away. So building on that last question and the results, how can we reduce the risk to the patients knowing that our potable water supply can be a source of contamination? Potable water isn't sterile and can include bacteria and microbes. So how do we be proactive? At TOH, we leverage 3 separate but all related ideas. 1, we perform water sampling. 2, we monitor quality of the water and the temperature of the water. And 3, we've developed and we've implemented a water management plan. So water sampling, first things first, we really do recommend that you partner to develop and perform a testing protocol for water quality. For our site, the number of locations is far too large, and it would be cost prohibitive to test every single one of the areas. As such, we test select areas on each floor, especially on those high-risk patient care areas. We also always test our hot water tanks because we know that these can be a source of Legionella. And again, our distribution is primarily through vertical risers with small horizontal connections. And for this reason, if we do get hit, and Jess touched on this, we will test the areas that are adjacent to it. This means above, below. It could mean 2 floors above, 2 floors below, but we also test those adjacencies as well. So once it comes up, we know it stubs off and feeds at least one washroom. Often there's a couple more washrooms that are on there, or kitchenette, that sort of thing. So all the areas that are connected, we try to sample those at that time. Although it's not as effective as hyperchlorination, it's well documented that high temperature is a good measure to help control or eliminate Legionella. And actually, I should step back from saying eliminate Legionella. Just wouldn't like that. So we can control it with a high temperature purge. One of the difficulties with this in healthcare is that the hot water temperature needs to be raised throughout the network, not just at the tanks. So in terms of water quality and temperature, CSA Z 317.1 does spell out the requirements for hot water in healthcare service providers. So table 1 shows all that information that's there. Not only the temperature that you have to be at, but like by user, what your hot water temperature is allowed to be. So one thing to note is that delta between those users. Those lower values are in patient care areas, and it's important to understand that it has to be lower in those areas because we're trying to prevent scald in those patient populations. So your infrastructure may not be sophisticated enough to ensure that patients or equipment are protected from raising the hot water temperature. So make sure to do your investigation beforehand before you unilaterally go ahead and raise the temperature throughout the system. The other point that I like to raise when we talk about Legionella and chlorination and the amount of chlorine in the water is that the higher you keep your loop temperature, the faster the chlorine is going to dissipate within the water. So just be wary that the higher that you keep that temperature, you might be consuming more chlorine. You might be injecting more chlorine than you have to achieve that higher water temperature. So on this slide, I just wanted to talk about some other ideas or items that can help with maintaining hot water temperature in your network. They include temperature sensors on hot water tanks and throughout the domestic hot water system. If sensors in the field demonstrate lower temperatures than required, it's probably a good indication that you've got an issue there. So it's a good way for facilities to be proactive in trying to determine maybe there's a cross connect there, maybe there's a dead leg, maybe there's a check valve that has failed, maybe there's a leak, maybe there's a leaking pipe somewhere, but it's an indication that there's probably some maintenance that has to be done. We talked about raising the temperature of the loop to help prevent or mitigate Legionella. There's some other methods that are out there. So these include UV systems, copper silver ionization, and increased chlorine concentration. All of these do require outside support before unilaterally installing, but I guess like the real thing that I want to indicate that there's no silver bullet to this. There's a confluence of ideas and systems that need to come together in order to really develop an approach to preventing bacterial growth in your potable water system. All right, so a water management plan. Really, your water management plan is like your best friend, and it's your best defense for reducing risk related to Legionella. So get to know your plumbing system. How's your water coming in? Where does it go? Are there areas that have been renovated or used differently that would lead to low flow conditions or stagnation? So healthcare needs to identify those areas in the plumbing system that can lead to this higher likelihood of Legionella being developed. With this, you can confidently identify areas where you may need to periodically flush due to unused water fixtures or other. Then make sure you do find a partner that you can be with who can provide that quarterly testing that we do look to have to make sure that Legionella isn't developing in your system. And lastly, track all of your testing. If you're not tracking it, you're not managing it, and you must manage what you measure to determine organizational risk and to help chart out where to test in the future. This could also include where you may want to install point-of-use filters in those problematic areas or in areas that are that have high risk for patient populations. Patient population, what kind of services are being delivered, how old's the complex in your station, all questions you should ask when developing your water management plan. Also, one big thing for us I found was mock code grays or tabletop exercises for the loss of water. So we partnered with emergency management and IPAC and clinical teams to go over, those water loss situations and properly identify how much water you'd actually need in those conditions. You'd be very surprised how much water you need, how much ice you might require, etc. during water loss situations. And there's some great toolkits out there. I found the CDC toolkit probably the most beneficial and helpful. So, don't be afraid to ask for help. The information is out there. Lessons learned. So two from the facility side. The first is don't take your plumbing system for granted. So start now to minimize the risk before there is a case. Audit your building for unused fixtures and plumbing dead legs and establish a flushing protocol. And when you plan on upgrading your infrastructure, think about products or systems that can help mitigate against stagnation. So just talked before about, we have many different faucets here, but there is some technology out there that can automate the flushing for you. So you don't need to have a full-time equivalent running around your hospital to perform those flushing exercises. And point-of-use filters, like get them while they're hot. Like they can take forever to show up. We're talking, 6 to 8 weeks to show up, and you do not want to wait for you to have a case to start the ordering. So get them as soon as possible. The other thing with regards to the point-of-use filters is that they do require adapters for your faucets. And if you don't have the right adapters, that point-of-use filter is not going on. So it's well and good to have the filters on hand. If the adapters aren't on hand, it's just as good as not having the filters to begin with. Hyperchlorination, that contact time is really, really important. However, and as a facilities guy, I've got to say, hyperchlorination is terrible for the condition of my copper pipes. The longer that chlorine stays in the system, the more biofilm gets removed, but also you'll have some of the wall of the pipes come apart. So you should expect during hyperchlorination that you'll have some areas where you will have leaks. And for that reason, I do suggest that during disinfection, have it be facilities led and call in additional contractors if required. So as you do the hyperchlorination, you can deal with leaks and the like as you go and not lead to some other issues in the system, mold growth, staining of walls, etc. During that process. You also want to make sure that you don't have any leaking valves. We talked about the importance of temperature and how high temperature water leads to chlorine dissipation. So if you have leaking valves in your hot water system, you might be artificially raising the temperature during that process. And that means it'll take longer for you to reach that CT time. We know from experience. Drain down your hot water tanks and shut off the heat to your hot water tanks during hyperchlorination. Again, if you don't do that, you're going to artificially raise the temperature of your loop, and it'll take longer for you to reestablish water to the floors. And I spoke about it at the start, but again, hyperchlorination is not something that you want to do repeatedly. Especially in a building like ours, 50 years old. I've got a building that's also 100 years old. We're really hanging on with some of that stuff. So the more hyperchlorination likely would mean like a system degradation as a whole, much bigger problems when it comes to water loss. So it's not a be all. We do not want to go back to it. So it's a one-time fix all, then rely on the other methodologies developed in your water management plan to reduce the risk.
So thanks, Ron. Just moving on to some of the lessons learned from our experience. Just think about the process and be informed about the process in advance. So we've emphasized really the multidisciplinary collaboration that's required in addressing this type of challenge, but plan in advance. Know who your stakeholders are, who they will be. This includes not only clinical teams who may be dependent on water, but also who you will end up or should consider consulting if you're investigating a similar problem. So for example, we work very closely with our own local public health unit, as well as with Public Health Ontario. We did retain an environmental consultant, as you've heard, and also think about who you would be able to contract for hyperchlorination if you needed to go that route. Testing techniques, there are differences in testing techniques that are used, and I referred to this earlier from the public health lab and also perhaps from environmental consultants. but we did find that quantitative PCR was a helpful tool for us. Also, recognizing that, for example, with rapid antigen tests, even though sensitivity may be poor, they may also allow you a much faster result that can inform some of your future process. Okay. I should point out that in the end, after all of this investigation, we did determine that our case was not hospital acquired, but we have had a similar incident late last year, and having gone through this once and having a more robust plan certainly facilitated our response to a similar incident in 2023. For patient care and clinical provider considerations, just be sure to consider what other areas would require particularly large volumes of water, but dialysis in particular. So have a plan, as Ron had alluded to manage a water supply interruption for specific clinical areas. We did have questions about how to bathe patients, whether they could take baths in a tub or have tub baths. We did use prepackaged baths in a bag. And for healthcare providers, we looked at setting up some basically jerry-rigged soap and water hand hygiene stations for them, where those might have been used, for example, in clinic areas that perform procedures where staff may need to wash their hands rather than use alcohol-based hand rub. There were a lot of questions about, are we able to flush the toilets? Most of our toilets do not have lids on them. Pros and cons to that. Jessica will get into that a little bit later. But we did allow flushing of toilets because we didn't have a better alternative, frankly. Staff had questions. If the water isn't safe for patients, is it safe for us? And we were very careful about consistency in our messaging, and we actually provided bottled water for staff and patients to consume on the units. Again, use of washrooms as usual for staff for personal hygiene. And then just make sure finally that you have a very good communication plan and that staff and patients and also the community are kept up to date with what is happening, and do this proactively and minimize any speculation that might develop if you don't have that clear, updated communication.
So taking those lessons learned and trying to apply them for future builds. So, we in Ottawa are very lucky to be where we are right now in terms of planning our new build. And so certainly some of this we are taking forward to apply to hopefully put ourselves in a better position to prevent these types of things from happening. So one of the items is to consider and discuss the pros and cons between vertical and horizontal plumbing distribution. There's benefits and drawbacks to each. As Ron mentioned, our system was based on 90 some odd vertical risers. So that can be really challenging if you're trying to just isolate a single unit. If you have a single oncology unit, and that's really the only unit that you would be considered at high risk, you don't have the ability to isolate that one unit if you're based on vertical risers. Horizontal system would allow you to do that. However, with a horizontal system, you're generally dealing with longer plumbing runs from the main to the fixture, which can increase the risk. More plumbing, more real estate for biofilm to settle. So no right answer here. It's just, you just want to make sure you have a fulsome conversation about which would be the best for a particular project. Fixtures, so as Ron mentioned, looking into auto purge fixtures. So many of the electronic eye faucets do have the ability to auto purge, so you can program them. Sometimes that can be a bit confusing for patients who are lying in bed sleeping and all of a sudden their hand hygiene sink faucet goes off. So there's certainly some communication that's needed around that. Design, so the faucet sink combination, as well as the toilet and flushometer combination, and making sure we're minimizing the spray of those devices. And there was a question in the chat about aerators. So aerators should not be installed in any healthcare facility and should be removed if they are present. The ideal flow restrictor is a single stream laminar flow device. They don't cause the same aeration that an aerator does, and so less splash and spray. And then kind of putting in some infrastructure elements, as Ron mentioned from the get-go, right? If you have a new build, you've got lovely, brand new, beautiful pipes. We'd like to keep them that way. So putting in a system like a UV system, additional chlorine pump, or a copper silver ionization system can help you keep those pipes looking good. In terms of some, I know we're running short on time here, so I'm just going to kind of put these up in terms of some additional information. These are the resources that we certainly looked at. The two first documents there are very technical ASHRAE standards, some great information in there, but they are very technical, not specific to healthcare facilities either. So they are general Legionella prevention documents. The one next to the third one over there, Ron mentioned in terms of the CDC developing a water management plan. Excellent document at really starting very baseline and walking you through that process. And then the fourth one there is the CSA standard on plumbing systems for healthcare facilities. A couple of other additional ones as well that provided some really good background. And then we have some resources listed here should you wish to delve further, and our selected references as well. There we go. Okay, so with that, we'll open it to questions.
Thanks so much for that, Jessica. Thank you to all of you for this terrific presentation and for answering some of our questions live. We do have a few that are open as well, so I will just open this up to the panel to ask. In addition to aerosolizing, aerators also provide surface area and trap retain material that facilitate biofilm growth and therefore can become a reservoir for Legionella. There was a previous question just about aerators in general, and I'm wondering if there's anything that you wanted to expand on that.
Yeah, that's absolutely correct. That the anything that's at the outlet of the faucet. So, you know, often I do the very technical inspection when we are looking at faucets. If you can stick your little pinky up into the faucet, that's usually a good thing. It means there's no grill or mesh or sieve there that can act as a substrate for biofilm. So yeah, fully correct.
Excellent. Thank you so much for that. And I think we have time for just one more quick one. It was just to finish off one of the questions at the beginning when you were talking about the hyperchlorination process, and just in terms of the water safety and what was available. I know all three of you sort of walk through what the water could be used, the risk communication plan as well. But I'm wondering if there's anything else that you wanted to expand on in terms of the limitations to the water use during the remediation.
I think from facilities, one of the big things during the hyperchlorination is that we had to disconnect and clean all the ice machines in the organization. That's a heavy lift, and it's a big impact on patients as well. So in terms of cleaning, it's not difficult. It just takes time, which means you have no ice. So luckily for us, our cafeteria is served from a different inlet on the potable water side. So we used cafeteria ice to supplement all the floors that required that medium while the water was out. So if you don't have a separate way to get ice, you're going to have to procure it from an outside source. That would be one thing that I wouldn't have thought of before the situation. Kathy or Jess?
We had actually done one of the lessons learned from this also when we had performed our second hyperchlorination was doing a water audit. So our emergency management group was really instrumental in doing water audits of the various units so that we had a better idea of what are your water usage needs, what are your critical needs, and making sure that they A, had enough, and B, in the different types that they would need.
Thank you so much. So we're at time now. And so I just wanted to wrap up today's PHO Rounds, and I'd like to thank Catherine Sue, Jessica Fullerton, and Ronald Drummond for presenting. I would also like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO Round survey for today's session. Please do try to complete this to help us improve our programming. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you all so much and have a great day.